Good afternoon, everyone, and welcome to the PHSSR Research in Progress series, Bridging Health and Healthcare. I'm Angie Carmen, and I'll be your moderator today. Our topic is injury-related infant mortality among vulnerable populations, the role of public health, primary care, and policy. Our presenter is Dr. Sharla Smith. Dr. Smith serves as an assistant professor in the Preventive Medicine and Public Health Department at the University of Kansas School of Medicine in Wichita. Dr. Smith's research focus concerns strategies for infant mortality, community health education, organizing and financing of public health services and programs, and partnership development. Dr. Smith earned a Master of Public Health degree in Health Policy and Management and a PhD in Health Systems and Services Research from the University of Arkansas for Medical Sciences. She is a 2014 recipient of the PHSSR Postdoctoral Scholar in Public Health Delivery Award. We will turn the presentation over to Dr. Smith, but right before we do, I will encourage all those of you who are on the line to use the chat box for any questions that you might have regarding the presentation. At the conclusion of Dr. Smith's presentation, we will turn the mic over to our commentators, and we have three. Each one of them will present a brief overview of their thoughts regarding the research, and after that we will use our chat box to entertain the questions from those of you on the line. So Dr. Smith, we'll turn the presentation over to you.
Thank you so much for that great introduction. Good afternoon, everyone. Today we're going to talk about injury-related infant mortality among vulnerable populations, the role of public health, primary care, and policy from a national perspective and from Arkansas perspective. So before I talk about the outline, I'd like to thank my mentors, Dr. Mary Akins and Dr. Zhu and Dr. Zenobia Harris. Today we're going to discuss the significance of the study, the public health delivery systems, which includes the primary care organizations, public health and policy, the role of primary care and policy in these delivery systems, the framework, social network analysis, which is used to measure the types of public health delivery systems, methods, preliminary findings, conclusions, and next steps. You may be asking yourself, why is this so important? It's important because unintentional injuries is the fifth leading cause of infant mortality. Specifically, Arkansas has the highest rate of injury-related infant mortality and hospitalizations than the nation as a whole. Broadly, the U.S. has the highest infant mortality rate compared to other industrialized countries. In 2010, the U.S. unintentional injury mortality rate for infants was 3.1 deaths per 1,000 live births. The most common cause of injury-related infant mortality includes suffocation, motor vehicle accidents and crashes, drowning, fires, burns, and poisoning. Unintentional injuries are predicted and preventable when proper safety precautions are taken. They are not what we consider accidents. So we conclude that by working together and creating these integrated public health delivery systems, public health and primary care and policy can leverage their strengths, and these agencies can conserve resources and achieve the capacity to deliver superior services of care for communities and the nation. So how will we examine this approach? This approach is examined from the approach of the public health and primary care delivery systems, which is the first component of the study. And these systems are comprised of public agencies and private organizations whose actions have significant consequences for the health of the public. So the role of primary care and policy is that the integration of public health and primary care increases public health awareness, that injuries are preventable, and empowers communities to work for change. Injury prevention efforts work best when supported by well-informed policy solutions. And policymakers benefit from public health and the support of primary care providers to work together to inform policy decisions to improve the effectiveness of state public health programs and improve population health. So the fundamental question, or where we begin, is basically looking at the context, mechanisms, and outcomes. So the context would be in what community setting. So this would look at the delivery systems among these public health, primary care, and policy organizations. And which programs, interventions, or policies as our mechanisms work best when looking at injury-related infant mortality, which is our outcome, and why, which could be the causal pathway or the interaction between these organizations. So to do this, we use the social network analysis measures to basically look at the type of delivery systems. And social network analysis tells us the nodes, which represent the organizations, the ties, which represent the relationships between those organizations. And we use two particular key measures of social network analysis to look at these public health delivery systems. Density is simply the number of ties divided by the possible number of ties. So it's the number of relationships or collaborative efforts between these public health delivery systems given the possible number of collaborative efforts between these delivery systems. And centrality is measured as a group measure. And so centrality is 0 to 1, and it tells us that it's equal 1 when all actors have the exact same centralization measure, and it's equal to 0 when they have the same index score, but it's equal to 1 when all actors choose the other actors and one actor stands out among those organizations. So the approach here is that the integration of primary care and public health may enhance the capacity of both sectors to carry out their respective missions. And this creates links with other stakeholders, policymakers, and other organizations to catalyze a collaborative intersector movement toward improved population health. So how is injury-related infant mortality in the United States and Arkansas? Specifically, when we look at the data from CDC, which examines sudden unexpected infant death and the causes of death, we can see that 45% of those deaths are sudden infant death syndrome. 31% of those are unknown causes, and 24% is accidental suffocations and strangulations. When looking at sudden unexpected infant death by race and ethnicity from 2008 to 2012, we can see that non-Hispanic blacks, which is our second column, are highly impacted by sudden unexpected infant deaths compared to non-Hispanic whites and Hispanics. So how does this look in Arkansas? Looking at the racial disparities in infant mortality in Arkansas, we see that non-Hispanic blacks are highly impacted by infant mortality, specifically resulting in 12.9 deaths per 1,000 live births, compared to 5.9 deaths in Latinos and 6.9 deaths in non-Hispanic whites per 1,000 live births. So the leading causes of infant mortality in Arkansas, among those are injury-related deaths. And so we look at two specific causes, and that is sudden infant death syndrome and accidental and unintentional death. And we can see that although not the highest impact among non-Hispanic blacks, that there is 12.8 deaths, 12.8% of those are SIDS deaths among African Americans, and 3% are accident unintentional deaths among African Americans. So that brings us to why this study is important. This study is important to provide a more in-depth understanding of the public health, primary care, and policy partnerships, and also to provide an understanding of how such partnerships are associated with injury-related infant mortality among vulnerable populations. So the first component of this study is to look at it from a national perspective, looking at the Association of Public Health and Primary Care, which we also refer to as healthcare organizations, and their association with injury-related infant mortality. In order to do that, we use the National Longitudinal Study of Public Health Agencies survey data from 2006 and 2012. And this survey was originally conducted in 1998, and it was a stratified random sample of the nation's 2,900 local health directors, and it was done again in 2006 and 2012 to determine the availability of 20 common public health activities within each local health department jurisdiction and to identify the types of organization participating in those activities. This data was coupled with the NACHO National Public Health Agency profile data for 2008 and 2013, and also includes the 2010 data. It also includes the Area Resource File data, which tells us the population characteristics for 2006 and 2013. The other component of the study is an interview that was done in Arkansas to look at injury prevention partnerships among policy agencies, public health, and primary care. So what are our findings from the National Longitudinal Study of Public Health Agencies? This graph basically tells us the difference in those organizations that local health departments indicated that they work with around these activities, and it shows us a decrease in these types of organizations over time. So from 2006 to 2012, there was a decrease in the number of community health clinics, hospitals, and physician agencies that were indicated by these local health departments that they work with to perform these activities. So in looking at the density and centralization of those agencies, we can see that density and centralization decreased from 2006 and 2012, meaning that these agencies are not working together as much from 2006 and 2012. So that collaborative effort and joint production is decreasing, as well as that level of centralization among those organizations. So when looking at the activities that these organizations perform, we can see that these agencies perform a very large number of policy activities, as well as a large number of assurance and assessment activities. So how do their preventive services for injuries look? We can see that they provide a large number of injury prevention services and tobacco services from 2008 to 2013, but they provide a limited number of violence and prenatal care services. And this tells us the importance of that collaborative effort to provide services to their communities. So now that we know the association between primary care and public health agencies and how their service delivery is being done and the limited number of services that they're provided, as well as the change in the number of partnerships over time, let's discuss the 2014 Injury Prevention Partnership Study from the policy perspective to identify the role of policy within these public health delivery systems and their association with injury-related infant mortality. So in looking at the role of policy and public health and primary care agencies, we originally identified 12 organizations to complete this study. And those participating organizations indicate whether or not they work with community health clinics, which are identified as primary care organizations, policy organizations, and public health agencies. And these partnerships were defined in the study as informal long and short-term relationships between two organizations that pool together funds, skills, resources, and advocate for policies to achieve a public health goal, particularly that to reduce injury-related infant mortality in Arkansas. The methods for this study was that a cross-sectional survey was administered to identify policymakers' awareness of injury-related infant mortality deaths and their collaborative efforts with public health and primary care agencies to address injury-related infant mortality. The preliminary data was coded to identify themes and assess patterns of variations between clusters, and network analysis is conducted to discover the relationship between a set of these policy, primary care, and public health agencies that have completed the study to date. So the findings from those interviews. So particularly one policy agency, which is our Arkansas Advocates for Children and Family, was asked the question to basically tell us their best guess, giving your best guess about what percentage of the population do you represent when advocating for policies that reduce or address injury-related infant mortality. And we asked them that not just from the infant's perspective, but from the maternal perspective as well. So how many of those individuals do you represent when it relates to the mother and the infant? And that agency told us that they represent about 46% of African Americans, 23% of non-Hispanic whites, 16% of Asians, and 15% of others. And that lets us know that these agencies are representing a large number of minorities when addressing or reducing injury-related infant mortality. So how does these networks look? This picture basically highlights the advocacy and policy network among those that have completed the study to date. And each organization was asked over the past year, which of the organizations has your organization worked with to advocate for policies or to implement policies to reduce or address injury-related infant mortality. The blue lines in this tells us the reciprocal relationship between those organizations, and the thickness of the line also highlights the reciprocal of the relationship. The agency of interest is the Arkansas Advocates for Children and Family, which is at the end of the diagram. And what this tells us that the Arkansas Advocates for Children and Family, the Arkansas Children's Hospital, Community Health Centers of Arkansas, the Arkansas Department of Health Injury Prevention Branch, March of Dimes, and the Office of Minority Health and Health Disparities all have reciprocal relationships with the Arkansas Advocates for Children and Family. So that means that they work together to address injury-related infant mortality when it relates to advocacy and policy. And it also tells us that the Hometown Health Initiative, which has also completed the study to date, didn't indicate that they worked with anyone at all to advocate for policies, and no one indicated that they worked with them as well. So we also asked these agencies about their frequency of interaction. We particularly asked them how often do they work with these agencies to address or reduce injury-related infant mortality. And the pink line tells us if they work with them less than 1 year, the green is 1 year, and the black is every few months, and blue tells us every few weeks, which indicates a strong relationship. The reciprocal ties are all very thick, and the non-reciprocal ties are very thin. And so what this tells us is that the Arkansas Advocates for Children and Family interacts often with the Arkansas Department of Health Injury Prevention Branch. The March of Dimes also works often with the Arkansas Department of Injury Prevention Branch and the Arkansas Department of Health. And the Hometown Health Initiative indicated that they work often with the Arkansas Department of Health Injury Prevention Branch. And the Community Health Centers of Arkansas indicated that they worked often with the Arkansas Children's Hospital. However, that was not a reciprocal relationship, so the Arkansas Children's Hospital didn't indicate that they worked often with them. Additional findings from the policy perspective is that the activities that they indicated that they perform for injury-related infant mortality are reporting and monitoring data, lobbying for legislation, providing resources to community health clinics. And they also indicate that they advocate for increasing access to health care coverage and health, and the health behavior work for pregnant women. When asked about the most effective service that was provided, they indicated that the most effective services are those provided to immigrant families. And the reason they indicated that is because they mentioned that the infant may be a United States citizen and the parents may not be a United States citizen, which limits them on actually assessing the health care that they need or receiving services for that infant, even if they are preventive services. So they indicated that those were the most effective services. When asked about the population at greater risk, they indicated that those are African American and single parent households. We also asked them about the most effective preventive strategies, and they indicated that the most effective preventive strategies are increased education and awareness. So the conclusions of this study is that local health departments provide a limited number of injury prevention services, and this highlights the importance of collaborative efforts. Policy organizations are very instrumental in supporting legislation to improve maternal and infant health. Policy organizations also distribute and share resources with many organizations to strengthen these efforts to improve population health, particularly when it relates to infant mortality, maternal and infant health. There are some limitations of this study. One of the main limitations is that many participating organizations have experienced a change in leadership. And this is a limitation for us because we may have to interview more than one individual from that organization to actually get a clear perspective on the work that they do to address injury-related infant mortality. Also, new initiatives are underway in Arkansas, particularly the CORN network. So this is a limitation for our study because there are new initiatives beginning in the middle of the study. But it's also a pro for us because we get to identify the relationships between these agencies early on when this initiative is beginning. And also there's an opportunity to examine these relationships as this initiative continues throughout the year. And then all interviews have not been completed. So as we complete interviews, we will have more information about the collaborative efforts between public health and primary care and policy. And additional data analysis are required to examine the association between public health and primary care and injury-related infant mortality. The policy and practice implications. So the policy implications are more efforts may also be needed to maximize the collaborative potential for partnerships among these agencies. Effective mechanisms to overachieve challenges faced in sustaining effective partnerships between public health, primary care, and policy are needed. And also with the practice implications, it's critical to establish a shared understanding of the nature, scope, and context of injury-related infant mortality within these communities when developing these partnerships. And it is vital to develop partnerships with public primary care agencies and policy organizations to address injury-related infant mortality. They're all working on these issues, so it's very vital to develop these partnerships early on and continue these partnerships with time. So the next steps of this study is, of course, to complete the interviews, which are in progress, and include data from all interviews, expand on the quantitative visualization of public health, primary care, and policy networks, and to examine the association of public health, primary care, and policy and injury-related infant mortality. Thank you so much.
Thank you, Dr. Smith, for your presentation. We can now move to our commentators, and we'll begin with Dr. Aiken, who is a professor in the Department of Pediatrics at UAMS College of Medicine and is the director of the Injury Prevention Center at Arkansas Children's Hospital. Dr. Aiken?
Yes, thank you. Good morning, or good afternoon now. I appreciate the opportunity to participate and to work with Sharla on this project, which is obviously of great importance. She reviewed the compelling data about why injuries really affect our infant mortality rates. I'd add just a couple of other highlights to that. She mentioned that it's number 5 overall for infant mortality, but in the first month of life, many infants succumb to prematurity or congenital birth defects of various sorts. If they make it to a month of age, really from there to the first birthday, injuries are by far the leading cause of death. So the problems that she's highlighting in her study are some of the most readily preventable causes of infant mortality, and the partnerships that are highlighted by her work are extremely important because none of the problems is simple to solve, whether it's safe sleep, homicide, which is also a big problem in this age group with shaken baby syndrome, or even motor vehicle safety, which we have good strategies to prevent, but we really don't always reach every parent. So I really applaud her for doing this. I think for me, I've learned a lot as I've watched her do the interviews because it's going to help, I think, us identify many of the gaps in communication between the relevant agencies. And as she said, it's quite complicated because in our state, there have been a number of transitions of leadership among the key organizations. So I think it'll highlight opportunities for new relationships to be formed amongst those leaders. So I think those are my main comments, but I thought her presentation was very helpful. So I'm looking forward to continuing to learn from it.
Thank you. I will encourage those of you on the line to use the chat box as you have questions, both for Dr. Smith and for our commentators. We'll move to our second commentator. Dr. Z is an assistant professor in the Department of Health Management and Policy at the University of Iowa College of Public Health. Dr. Z?
Good afternoon. Thanks for the opportunity to work on this project and collaborate with Dr. Smith and Dr. Aiken. My commentary will focus on the methodology that Dr. Smith is using to address this very important issue. I think for the substantive issue, both Dr. Smith and Dr. Aikens fully addressed with, why this problem is important, why this issue is important. But I think, what's exciting in this study is the methodology that Dr. Smith is using. So the background of that is the current movement towards managing health and health care beyond the hospital walls, and the cross-sector collaboration that a lot of thought leaders are trying to push the field and also foster cross-sector collaboration. I think the uniqueness of the social network analysis, it gives a very granular understanding of data to show how the system is currently working. As Sharla showed us of policy and other advocacy efforts, there is certain collaboration exists in the system, others. So it tells us how the system is currently working. It also tells us various aspects of that current system structure in terms of partnership. All those information help us to address potential challenges and promoting better health and reducing cost by. Another exciting aspect of this study is that it goes beyond just the care sector, that the partnership between policy sector. So those three aspects are the strengths of the study, and I think there's even more exciting potential from the study, which I'm going to address in 3 points. The first point is that it helps us to identify important partnerships that's currently missing. And the second point is that help us to leverage our understanding of how cross-sector collaboration work better, which is creating a backbone organization or identifying some organization better position to take on that back position to facilitate future cross-sector collaboration. A diagram that Sharla showed us at the Arkansas Advocates for Family and Children is one of the organizations closely collaborating with other center of the social network, partner network, and that's giving us some better position. Last point of future potential is to intention of this and why certain important collaborations are the policy, practical, local factors are presenting more closely. So I have some questions in the survey to ask about that. So together with those 3 points, I think the study will significantly improving the system. So intervention.
Thank you very much. We have one more commentator. Zenobia Harris is the Regional Director at the Arkansas Department of Health and the Arkansas State Coordinator for the Birthing Project USA. Dr. Harris?
Thank you, and thank you for the opportunity to participate in this really important discussion. My experience has been primarily focused in local public health and local public health department activity. And as we have worked with practice and policy organizations collaboratively, sharing best practices and sharing data that we collect and that they collect has been instrumental to us in looking at the way that we provide training and education to our staff, who in turn provide direct services to clients in our WIC clinics, our immunization clinics, as they're interacting with parents, providing health-related messages, and also messages that relate to baby safety, educating parents about safe sleep practices, about shaken baby syndrome, hosting safe baby showers to give individuals in our communities opportunities to come and learn more information about what constitutes safe delivery of care to children or infants. And then the whole collaborating piece in terms of with mentoring organizations, Birthing Project USA, which is a national mentoring program focused on providing support to African American women during pregnancy and during the first year of life of their babies. We've instituted some of the Birthing Project mentoring programs into our local community outreach programs, particularly in the Delta portions of the state of Arkansas, to provide more consolidated support to women in our communities who don't traditionally utilize local health departments fully or don't feel comfortable working with the local health departments in some of the more traditional ways that we offer services. And so we see that whole partnershiping piece, the ability to utilize what we've learned as a health service organization, but also the things that we've learned partnering with Children's Hospital and other service providers out there as a way for us to kind of pay it forward, if you will, in terms of using the best resources that we have available in our communities to enhance those health messages and to better promote safety for our infants and children.
Thank you very much. I would open it up to our participants and again invite you to use the chat box if anyone has a question. And while we wait for questions, Dr. Smith, if there's anything else you would like to add, now that the commentators have given a few comments about the research, we certainly welcome you to do that.
Okay, thank you so much. So I think now that the commentators have given their perspective of the research, that they've really highlighted the importance of these partnerships to address injury-related infant mortality. I think the last thing that I would say is that these policy relationships are going to be very instrumental in addressing injury-related infant mortality, probably not only in Arkansas, but throughout the United States. And this study brings a very innovative perspective to examining not just the integration of public health and primary care, but also the role of policy and how those organizations will play a vital role in addressing injury-related infant mortality as well as other health outcomes.
Dr. Smith, are you noticing anything in your research, especially with partnerships, of new or what we might call non-traditional partners that are working in this area?
Yes, particularly when I talk with agencies, I'm finding out that there are school communities and other community or neighborhood associations that are working with these agencies to advocate for policies or to address injury-related infant mortality or maternal health throughout the United States and throughout Arkansas. So I'm finding that these agencies also work with local schools, they work with local community associations, and I'm also finding out that they may work particularly with some agencies that advocate for a particular policy. So if there is an advocating agency, they work with them. And also in Arkansas, we have a Sisters United group, and so that group started with the Office of Minority Health and Health Disparities, and so that agency is very vital in addressing infant mortality and injury-related infant mortality in Arkansas. And that group is a group of sororities, Delta Sigma Theta, Alpha Kappa Alpha. So these are African American sororities that work together to address infant mortality with other agencies in the state.
That's great. Are you in your interview process talking at all about barriers that the partners are having or things that make coming together to work on these issues more more likely to be sustainable or to be effective?
We are talking about challenges, and what I found is basically most of the challenges are capacity, so having the capacity and funding. So having the funding to do these types of activities, and also the distribute of time to work on a particular thing, because a lot of these, particularly when looking at the policy organizations, a lot of these organizations advocate for things other than infant mortality or injury-related infant mortality, are particularly maternal health. So they have a broad agenda of the things that they advocate for. So they only allocate a small amount of their time to this particular health outcome.
Right. We do have a question in the chat box that says, Dr. Smith, what would you recommend, or what are your lessons learned for researchers in other states who would undertake a similar policy network analysis?
I would recommend that one thing that I've learned from this is that it would probably be best to talk with that identify the main policy organization, that organization that advocates most of their time to the outcome that you're looking at, and then from there identify other agencies that they work with, because what we're finding as we complete the interviews is that there are agencies that we didn't consider in the initial 12 that may be very vital or play a very vital role in these partnerships. So I would definitely recommend that you find that agency that is central, and then work with them to identify the agencies to interview.
Thank you. We'll allow any other questions to be placed in the chat box as we wind down today. We have an unusually quiet group of participants, it seems like, today, but it could be because the presentation was very well put together and our commentators provided some excellent thoughts as well. If we don't see any other questions, I will direct your attention to the screen for our future webinars, especially in July. On Wednesday, July 1st, we have the Affordable Care Act and childhood immunization delivery in rural communities. And then on Wednesday, July 8th, we have the National Evaluation of Leadership Styles and Outcomes in Local Health Departments. So we do very much appreciate your participation today. We're giving you back approximately 20 minutes in your day, which I'm sure that you can use. And we do want to especially thank Dr. Smith and all three of the commentators for providing their information today. So thank you very much for participating, and we'll see you next time.